Welcome to today's webinar called Donor Eligibility, What Does the FDA Have to Say? Presented by Dr. Michelle McClure with, drumroll please, the Food and Drug Administration. Dr. Michelle McClure has been a biologist with the FDA's Office of Tissues and Advanced Therapies in the Division of Human Tissue since 2004. Her primary focus is policy development and regulatory review as it relates to the eligibility of donors of human cells and tissues. A perfect guest for us. Dr. McClure has previous work experience in a cardiovascular and orthopedic tissue processing laboratory at a biotechnology company. Prior to joining the FDA, Dr. McClure received a PhD in genetics, and her studies focus primarily on improving our understanding of the biochemical defects that cause cystic fibrosis. Man, that was a challenge to my pronunciation skills this morning, Dr. McClure. We first met Dr. McClure as a fellow presenter at the American Board of Tissue Banking Convention in Arizona, and we are so pleased to have so many fertility clinic professionals joining us this morning. I know all of us will find some point of enlightenment from Michelle's presentation. We won't have time for Q&A this morning, but Michelle will be sharing with us how you can submit your questions and get timely answers from the FDA. If you are experiencing any technical difficulties during the presentation, please contact WebEx Technical Support. Get your pens and pencils ready. Here's the phone number, 866-229-3239, and as a reminder, this presentation is being recorded today. Thank you so much, Dr. McClure, for joining us. I turn the presentation over to you.
Okay, well, thank you. Can everybody hear me okay?
I think they can.
All right, great. Well, first I want to thank you for the opportunity to speak on this topic, and I especially want to thank everybody who has taken time out of their busy schedules to tune into this talk. So my goal for today is to provide an overview of FDA's regulatory approach as it applies to reproductive cells and tissues. So I will begin today by providing a general overview of FDA's regulatory authority for human-derived cells and tissues, as well as some important information about registration and listing requirements for cell and tissue establishments. The majority of this talk will focus on the donor eligibility requirements, including some special exceptions that may be applied to donors of reproductive cells and tissues. And then lastly, I will provide some information about helpful resources, including how to contact FDA should you have questions about the regulatory requirements. So before we get started, I do want to remind everybody that this presentation is not necessarily a complete listing of all FDA regulations, and you should refer to Title 21 of the Code of Federal Regulations, Part 1271, for a complete listing, and a link to the electronic version of these regulations is provided at the end of this presentation. So let's begin with a general overview of FDA's regulatory authority for human-derived cells and tissues. So FDA is divided up into several main centers, such as those for drugs, medical devices, tobacco, foods, and veterinary medicine. Human reproductive cells and tissues are covered by the Center for Biologics Evaluation and Research, often called CBER for short. CBER is further divided into offices, and the slide that I've shown here shows the different offices in CBER. And I've highlighted a few offices that you should be aware of. The first is the Office of Compliance and Biologics Quality, or OCBQ. Among other tasks, this is the office that handles compliance issues that may arise during an inspection of your facility. Now, the individuals that actually come in and inspect the facility are not part of OCBQ. They're actually under an office that is not part of CBER directly, but they communicate their findings to OCBQ, and then OCBQ handles everything from there. So the next office that I've highlighted is the Office of Communication, Outreach, and Development, or OCOD. One key function of this office is to provide communications to our stakeholders. This includes providing a single point of contact for establishments or consumers that have questions about CBER policies or products regulated by CBER. And then the last office that I've highlighted is the Office of Tissues and Advanced Therapies, or OTAT. This office handles policies for a variety of biological products, including human cells and tissues. some of you may have been familiar with the office's previous name, which was the Office of Cellular, Tissue, and Gene Therapies, or OCTGT. But as part of a reorganization that occurred in 2016, OCTGT was dissolved and OTAT was created. So OTAT is further divided up into 5 divisions. And so on this slide, I have highlighted the Division of Human Tissues, or DHT, which is the office that specifically handles policies for human-derived cells and tissues, including reproductive cells and tissues. And this is also the division that I work in. So this slide just gives you an idea of some of the types of products that OTAT handles, such as cell and gene therapies. But you see at the bottom of this list is the product category that we're focusing on today, and these are the human cells, tissues, and cellular and tissue-based products, or HCTPs. So HCTPs are defined as articles containing or consisting of human cells or tissues that are intended for implantation, transplantation, infusion, or transfer into a human recipient. The column on the left provides some examples of articles that are considered HCTPs, and the column on the right lists some examples of articles that are not considered HCTPs. Most importantly, this table shows that reproductive HCTPs, such as oocytes, semen, and embryos, are considered HCTPs, and therefore FDA's policies for HCTPs applies to oocytes, semen, and embryos. So FDA's regulatory framework for HCTPs is divided into 2 regulatory tiers. The first tier is what we typically refer to as 361 HCTPs. These are HCTPs that are regulated solely under the authority of Section 361 of the Public Health Service Act, or PHS Act, which authorizes FDA to make and enforce regulations necessary to prevent the introduction, transmission, or spread of communicable diseases. These tissues are subject to the tissue rules listed in 21 CFR Part 1271, and pre-market review is not required. However, to be regulated as a 361 HCTP, the HCTP must meet all of the criteria set forth in 21 CFR Part 1271.10a. Reproductive cells and tissues that are intended for reproductive use are considered 361 HCTPs, and therefore they must comply with the applicable tissue rules. Now, the other regulatory tier is for HCTPs that are regulated as drugs, devices, and/or biologics. I won't focus on these so much today because reproductive HCTPs intended for use and reproduction, intended for reproductive use are not, do not fall under these categories. But in general, these HCTPs are those that do not meet all the criteria under 1271.10a and therefore are regulated under the authority of Section 361 of the PHS Act as well as Section 351 of the PHS Act and/or the Food, Drug, and Cosmetics Act. So these products are subject to the 1271 tissue rules as well as pre-market review requirements that are listed in the other sections of Title 21 of the Code of Federal Regulations. So as I mentioned, the tissue rules are listed in Title 21 of the Code of Federal Regulations, or CFR, Part 1271. The regulations in this part are divided into 6 subparts. There's Subpart A, General Provisions, Subpart B, Establishment, Registration, and Listing, Subpart C, Donor Eligibility Determinations, Subpart D, Current Good Tissue Practices, or CGTPs, Subpart E, Additional Requirements, and Subpart F, Inspection and Enforcement. Now, Subparts D and E are in gray on the slide because they do not apply to reproductive cells and tissues, with the exception of 2 specific regulations noted by the asterisk. And this mainly just refers to the option for requesting exemptions and alternatives to the donor eligibility requirements. All right, so now I'm going to move on to a high-level overview of establishment, registration, and listing requirements. So 1271.10 explains that all establishments that manufacture an HCTP must register and list their HCTPs, which includes providing information about the establishment and the HCTPs that they manufacture. These requirements apply to both domestic and foreign establishments. Now, it is important that you understand what FDA means by the term manufacture. Manufacture includes any and all steps in recovery, i.e. the collection, processing, storage, labeling, packaging, or distribution of any human cells or tissues, and the screening or testing of the cell or tissue donor. And by establishment, FDA means a place of business under one management at one general physical location that engages in the manufacture of HCTPs. This includes an individual, a partnership, cooperation, association, or other legal entity and facilities that engage in contract manufacturing services. So as explained in FDA Small Entity Compliance Guidance, one general physical location could include separate buildings within close proximity, provided that the activities in them are closely related to the same business enterprise, under the supervision of the same local management, and capable of being inspected at the same time. So there are some exceptions from the registration and listing requirement. Two important exceptions that I want to highlight here are establishments that only receive and store HCTPs solely for the use within their own facility. In other words, they are not performing any other manufacturing steps. And establishments that only recover reproductive cells or tissues for immediate transfer into the sexually intimate partner. So in these scenarios, registration and listing are not required. It is also very important to note that FDA's acceptance of an establishment's registration and HCTP listing does not constitute a determination that an establishment is in compliance with applicable rules and regulations, or that the HCTP is licensed or approved by the FDA. So some highlights of the registration and listing requirements include that an establishment must submit an amendment to their registration if there is a change in ownership or location, and for international establishments, if there is a change in the U.S. agent's name or contact information. Establishments are required to update their registration annually, even if there are no changes. The annual update period is November 15th through December 31st, and additional details are listed in 21 CFR Part 1271.21 and 1271.25b. Also, if an establishment has gone out of business or no longer manufactures any HCTPs, then the establishment should inactivate their registration. And again, I want to remind you that these slides do not contain all the details about registration and listing, and so I strongly encourage you to review the regulations that I have listed on these slides. Right, so now I will move on to the main focus of today's presentation, which is the donor eligibility determination. I will first start with some of the general requirements, then I will move on to specific screening and testing requirements, as well as some exceptions to the regulations. So first, what is a donor eligibility determination? So a donor eligibility, or a DE, determination is based on screening and testing of HCTP donors for relevant communicable disease agents or diseases, which I may also refer to as RCDADs. A DE determination is required for all donors of cells and tissues used in HCTPs, with some exceptions that I will cover later in this talk. And an HCTP must not be implanted, transplanted, infused, or transferred until the donor has been determined to be eligible, again with some exceptions that I will cover later. So for all donors, FDA has identified the following RCDADs: HIV 1 and 2, hepatitis B and C viruses, human transmissible fungiform encephalopathies, including CJD and VCJD, Treponema pallidum, which is the agent that causes syphilis, vaccinia, sepsis, West Nile virus, and Zika virus. Now, the first 5 agents on this list are described directly in the 1271 regulations. The last 4, however, were identified as RCDADs after the 1271 regulations had been published, so they are described through guidance documents. So vaccinia, sepsis, and West Nile virus were identified and described in the 2007 donor eligibility guidance, and Zika virus was described in the recent Zika-specific guidance that was published in March of 2016. So going on for viable leukocyte-rich tissues, such as semen, HTLV 1 and 2 are also considered RCDADs. And then for all reproductive cells and tissues, chlamydia and gonorrhea are also considered RCDADs. Now, I just want to point out that these are everything that we have listed as an RCDAD. However, some of these we require screening for, some of them we require testing for, some we require both. And I'll go through the details of screening and testing later in this presentation. But I just want to point out that just because something is on this list doesn't necessarily mean that testing is required. For example, there are no appropriate tests for vaccinia or sepsis. Therefore, we cannot require testing. However, we have screening recommendations that we have put in place instead. And again, I will go into that more in just a moment. All right, so when is a donor eligible? In order for a donor to be considered eligible, donor screening results must indicate that the donor is free from risk factors for and clinical evidence of infection due to an RCDAD, and that the donor is free from communicable disease risks associated with xenotransplantation. In addition, donor testing results for RCDADs must be negative or non-reactive, with one exception for a non-treponemal syphilis test, which I will discuss more about in just a moment. So for reproductive HCTPs, the type of donor is based on the relationship of the gamete donor to the recipient, and this is regardless of who the intended parent is. So for example, a gestational carrier is considered the recipient of the HCTP even if that gestational carrier is not the intended parent. So in other words, an intended parent may also be considered a donor. So for regulatory purposes, a donor for reproductive HCTPs may be an anonymous donor, a directed donor, or a sexually intimate partner. So FDA defines a directed donor as a donor of reproductive cells or tissues to a specific recipient who knows and is known by the recipient before donation. So this includes semen, oocytes, and embryos to which the donor contributed the spermatozoa or oocyte. Right, so now I'll move on to some specific information about donor screening. So the 1271 regulations explain that you must determine a donor to be ineligible if you identify any communicable disease risk associated with xenotransplantation, or if you identify a risk factor for or clinical evidence of any of the RCDADs for which screening is required. Currently, donor screening is required for the following RCDADs. For all donors, this includes HIV, HBV, HCV, human TSCs, including CJD, Treponema pallidum, West Nile virus, Zika virus, sepsis, and vaccinia. For donors of viable leukocyte-rich tissues, such as semen, this also includes HTLV. And then for donors of all reproductive cells and tissue, you must also screen for chlamydia and gonorrhea. So part of the donor screening process includes review of relevant medical records. Relevant medical records include a current donor screening or current donor medical history examination, a current report of the physical examination, and other records if available. So other records may include, but are not limited to, additional lab test results other than those already required by FDA, medical records, or any relevant information from other sources. I know you see on this slide there are also things like coroner and autopsy reports, but just keep in mind that some of these regulations that I'm going through apply to donors of other types of tissues that are recovered usually after death. All right, so you must review these relevant medical records and ask questions about the donor's medical history and relevant social behavior, including risk factors for RCDADs and communicable disease risks associated with xenotransplantation. A list of conditions and behaviors that increase the donor's relevant communicable disease risk can be found in Section 4E of the Donor Eligibility Guidance. Due to time limitations, I will not go through this entire list, but I strongly encourage you to review the list closely. You must also review the relevant medical records for clinical evidence of RCDADs. And again, I won't go through this list, but a list of examples of clinical evidence that you should consider is provided in Section 4F of the Donor Eligibility Guidance. And all these guidance documents that I'm mentioning throughout this presentation, for all of them, I provided a link to them at the end of the talk. Okay, and then in addition, you should review the records of the physical examination for any signs that might indicate a high-risk behavior for an infection with an RCDAD. For this, you may rely on records or a recent report of a physical examination by other health professionals. And for living donors, you may examine only those parts of the body that are necessary to evaluate for RCDADs based on results of the medical history interview and review of available records. So a list of examples of physical evidence of RCDADs or high-risk behaviors can be found in Section 4G of the Donor Eligibility Guidance. So if you have performed a complete donor screening procedure on a living donor within the previous 6 months, then you may use an abbreviated donor screening procedure for repeat donations. However, you still must determine and document any changes in the donor's medical history that have occurred since the previous donation that would make the donor ineligible, including relevant social behavior. So for example, you do not need to conduct a new physical examination or a new review of relevant medical records, but you should remind the donor about behaviors that could put him or her at risk of relevant communicable diseases. And you should ask the donor if there have been any changes in the donor's history or risk factors since the previous donation. And again, this applies only if a complete donor screening procedure has been performed within the previous 6 months. Now, since Zika virus is a relatively new RCDAD, I wanted to take a moment to provide some additional information about the virus and FDA screening policies. A guidance document for screening HCPP donors for Zika virus was published on March 1st, 2016. To date, this is the only Zika-related guidance that FDA has published for HCPPs. Any other guidances that you might see are written for blood and blood components and do not apply to HCPPs. So with regards to the HCPP guidance that was published on March 1st, 2016, this guidance identified Zika virus as an RCDAD and provided information about donor screening. For living donors of HCPPs, which includes semen, oocytes, and embryos, you should consider the donor ineligible if they have any of the following risk factors. 1, a medical diagnosis of Zika virus within the past 6 months. 2, residence in or travel to an area with active Zika virus transmission within the past 6 months, and I will talk more about active areas in just a moment. Or 3, sex within the past 6 months with a male who is known to have either of the Zika risk factors listed in items 1 or 2. So this slide lists some of the reasons why we have established the current screening approach for living donors. We know that approximately 80% of infected individuals are asymptomatic, and the virus can cause serious birth defects. Numerous cases of sexual transmission have been reported, and sexual transmission has even occurred from asymptomatic males. Zika RNA has been identified in semen as late as 6 months after the point of infection, although in these cases it's unclear at what point the virus may have become non-infectious. However, infectious virus has been detected in semen as late as 69 days after symptom onset, and the upper limit of this viral persistence remains unclear. Zika RNA has been detected in tissues such as semen, even after it is no longer detectable in blood, which makes the traditional approach to donor testing a challenge. And lastly, Zika has been detected in the cellular component of semen, which suggests that sperm washing techniques may not be effective against Zika virus. However, there are numerous studies currently underway to help us better understand this virus. So as I mentioned on an earlier slide, as part of FDA's screening approach for Zika virus risk factors is based on residence in or travel to an area with active, i.e. mosquito-borne, Zika virus transmission, and this is as identified by the CDC. So in the guidance document that was published in March 2016, FDA provided a link to a CDC website on Zika. This website contains a special link for the blood and tissue collection community, and the specific URL for that link is listed here on the slide. The page that this link goes to is what establishments should use to identify active areas for the purpose of donor screening. We recommend that you check this page often for updates and changes to the active areas. When you go to this website, you will notice that the page identifies areas as active or previously active. There is no map on this page, and there are no red or yellow areas. So if you're looking at a map or information about red or yellow areas, then you're looking at the wrong page for the purpose of donor screening. And this is important to be aware of because these defined areas of active transmission may be different from areas for which CDC has issued travel guidance. And this is because the risks and concerns for different populations may be evaluated differently. For example, the information that CDC provides for pregnant women, which is listed on their pregnancy website, is different from the information for determining eligibility of a donor. So this is a screenshot of the top of the website that you should be using when screening a donor for travel or residence risk, and the exact URL is listed at the top of the slide. The red arrow points to the beginning of the list of areas of active transmission. This list contains areas within and outside of the United States, and also the dates for which the area is considered active. Now I want to point out this little gray box at the top, which the blue arrow is pointing to. This box talks about a potential increased risk to donors based on the potential that donors in certain non-active areas in Florida could travel in and out of areas with active transmission as part of their normal daily activities and not be aware that they traveled into an area with active transmission. Therefore, out of an abundance of caution, CDC provided information about these additional counties. The areas described in this gray box are not areas with active transmission unless they are also listed under the active areas section below. So residence in or travel to an area that is not active would not make a donor ineligible, and establishments can decide if there's any additional considerations that they want to make regarding these non-active but potentially increased risk areas. So people often ask about testing donors for Zika virus. Currently, FDA does not provide any recommendations on donor testing for Zika. We work closely with U.S. government partners and manufacturers interested in developing tests for HCTP donors, and will consider testing recommendations once appropriate tests are available. In the meantime, if testing is performed in addition to donor screening, the results of that test must be included in the donor's relevant medical records. A donor is considered ineligible if a test is reactive or positive, even if it was an investigational test that was used. However, a negative or non-reactive test does not override any risk factors identified in the March 2016 Zika guidance. So in other words, if a donor lives in or has traveled to an active area within the past 6 months, there is no scenario in which the donor can be considered eligible regardless of any testing that is done. And as I mentioned earlier, certain cells and tissues, such as semen, have been found to be positive and infectious even when the virus is no longer detectable in that individual's blood. Therefore, a negative blood test does not guarantee that other cells and tissues are free of the virus. And so keep in mind that there are certain scenarios in which you are allowed to use these HCTPs from an eligible donor and scenarios in which screening and testing are not required, and I'll go through more of those in detail later in this talk. All right, so now I'll move on to some information about donor testing. So in general, testing must be performed using an appropriate FDA licensed, cleared, or approved donor screening test, with the exception of chlamydia and gonorrhea, which are clarified in 1231.80C. For chlamydia and gonorrhea, there are no screening tests available, and therefore we make an exception for the use of certain types of diagnostic tests instead. But in all cases, the test must be performed according to the manufacturer's instructions for use, and they must be performed in a laboratory that has been certified by CLIA for performing those functions, or an equivalent as determined by CMS. So the specimen that's used for donor testing must be collected at the time of recovery or collection of the HCTP or within 7 days before or after recovery. For donors of oocytes and certain hematopoietic progenitor cells, the specimen may be collected up to 30 days prior to or within 7 days after the HCTP is recovered. However, please note that this 30-day extension does not apply to semen donors. There are some additional criteria for anonymous semen donors. For all anonymous semen donors, you must collect a new specimen at least 6 months after donation of the semen and test that specimen again for all required communicable disease agents. In other words, each donation must be quarantined for at least 6 months, and you must have at least one complete set of test results both before and after the 6-month quarantine period. So if a repeat donor discontinues donations, you should wait at least 6 months from the final donation and retest the donor to qualify the final donation, with the exception that you can use the results for chlamydia, gonorrhea, and West Nile virus that were obtained at the final donation or any time afterwards as a follow-up test. And in addition, for repeat semen donors for whom retesting is required, such as anonymous donors that I just described, you do not have to collect a new specimen for testing at the time of each donation. All right, so when is a donor considered ineligible based on testing? So, excuse me. A donor whose specimen tests positive or reactive on a screening test for an RCDAD would be considered ineligible, with one exception for syphilis tests. So for syphilis, a donor with a reactive non-treponemal screening test for syphilis may be eligible if a subsequent treponemal-specific test is performed and found to be negative. However, if a donor has a positive treponemal-specific test, they are considered ineligible. Donors must also be assessed for plasma dilution sufficient to affect test results, although this is likely a rare finding for reproductive HCTP donors. So this slide is provided as a reference to help you understand when a donor is eligible or ineligible based off of syphilis test results. As you can see, if you start with a non-treponemal screening test, if that test is non-reactive, then no further testing is required. However, if you start with a non-treponemal screening test and the result is reactive, then that donor is considered ineligible unless you retest using a specific treponemal test and that result is found to be non-reactive. If that result is reactive, the donor is ineligible. On the other hand, if you do your initial screening using a treponemal-specific screening test, then the algorithm is much simpler. If that test is reactive, the donor is ineligible, regardless of follow-up testing, or if that test is non-reactive, the donor is eligible. And the reason for this difference is that a donor who has been previously successfully treated for syphilis may stay positive on a treponemal-specific test for much of their life, and they don't necessarily have an active syphilis infection, and so because of that reason, we allow this other option for a non-treponemal screening test. However, the non-treponemal screening test may show up as positive for other types of conditions, and therefore we have that option to do a treponemal confirmatory test. So each establishment may choose which of these algorithms they want to follow. All right, so the key thing to remember here is that if a donor has a positive treponemal-specific test at any point, they will be considered ineligible. However, keep in mind that once a donor has been successfully treated for syphilis and at least 12 months have passed since successful treatment, then a new donor eligibility can be made, which includes repeating all the required screening and testing, and the donor may be eligible provided that syphilis testing is now negative. And information about how you handle past syphilis tests can be found in Section 4E of the 2007 Donor Eligibility Guidance. So what agents do you have to test for? As I mentioned, just because something's an RCDAD doesn't mean that there's a test available. So this slide lists the agents that we currently require testing for. So all donors of HCTPs must be tested for HIV 1 and 2, HBV, HCV, and Treponema pallidum. All living donors must also be tested for West Nile virus. Donors of viable leukocyte-rich HCTP, such as Semen, must also be tested for HTLV types 1 and 2 and CMV. Now, you may have noticed that CMV was not on the RCDAD list. Since CMV is not an RCDAD, a positive test does not necessarily make the donor ineligible. Instead, FDA requires that you establish and maintain procedures governing the release of an HCTP from a donor that tested positive for CMV. And if you have questions about the clinical significance of using an HCTP from a CMV positive donor, you may want to contact appropriate healthcare professionals or the CDC. Although use of HCTPs from a CMV positive donor is not prohibited by FDA, there may be other clinical reasons why you may or may not want to use that HCTP. And then for donors of any reproductive HCTPs, you must also test for chlamydia and gonorrhea. And for some of these agents, more than one type of test might be necessary to adequately and appropriately test for the RCDAD. So I'm not going to go through this entire table, but this provides a summary of the specific types of tests that FDA has identified as necessary to adequately and appropriately test for each RCDAD. For example, for HIV-1, FDA recommends using an FDA licensed screening test against HIV-1 antibody, as well as an HIV-1 NAT test or nucleic acid test. And that's just one example where more than one test is considered necessary to adequately and appropriately test for evidence of an RCDAD. So all of this information can also be found in the guidance documents, which I've listed in the white box at the bottom of the slide. And again, links to all these documents are provided at the end of this presentation. So I just wanted to take a moment to provide some additional information about West Nile virus testing. The guidance was published in September 2016, which explained the need to test living donors for West Nile virus using a licensed nucleic acid test, or NAT test. In the United States, this testing may be limited to June 1st through October 31st of each year. However, for establishments that are located outside of the U.S., they should implement West Nile virus testing year-round. And the reason for this is that data is available, epidemiological data is available to us to review for the United States, and so we can identify when the peak mosquito seasons are and continue to monitor that. However, that type of information is not necessarily available to us for other countries, and therefore West Nile virus testing year-round should be implemented. Now, any donor with a reactive or positive West Nile virus test is considered ineligible, and this testing requirement is in addition to the screening criteria described in the 2007 donor eligibility guidance, which explains that if a donor had a medical diagnosis or suspicion of West Nile virus infection within the past 120 days, or they had a positive or reactive test for West Nile virus within the past 120 days, then the donor is ineligible. That means that if a donor tests positive, you may wait 120 days, then perform a whole new donor eligibility determination, including testing for West Nile virus. If the donor tests non-reactive at this point, then he or she may be eligible to donate, provided that all other screening and testing requirements are met. Now, for repeat semen donors from whom a specimen has already been collected and tested, and for whom the 6-month quarantine and retesting is required, you are not required to collect the donor specimen for testing at the time of each donation. However, you should collect a specimen for West Nile virus NAT testing for the first donation that occurs within that June 1st through October 31st testing period, even if an earlier specimen was collected and tested. So now I'm going to take just a few minutes to go through some important exceptions to the donor eligibility requirements that you should be aware of. First, there are scenarios in which you may use an HCTP from a donor who has been determined to be ineligible. This includes reproductive HCTPs from a directed reproductive donor, which is defined in 1271.3L. If you use an HCTP under this exception, there are special labeling and physician notification requirements that you must follow, and you must document that you notified the physician of the results of RCDAD screening and testing. So although FDA permits the use of HCTPs under this exception, an establishment or treating physician may decide not to accept these risks. There is still a clinical decision there that has to be made regarding whether or not you're going to still use these HCTPs, even though FDA does not prohibit their use. Now, this exception applies only to donors for whom the donor eligibility determination has been completed and the donor was found to be ineligible. For example, if you identify that a donor has a risk factor that will result in an ineligible determination, you cannot just stop there and call the donor ineligible. You must complete the donor eligibility determination so that you identify all potential risk factors so you can communicate those to the physician appropriately. There are some exceptions for use of HCTPs prior to completion of the donor eligibility determination, but those exceptions do not apply to reproductive HCTPs. So there are also several scenarios in which a donor eligibility determination is not required. So this includes cells and tissues for autologous use, reproductive cells and tissues donated by a sexually intimate partner of the recipient for reproductive use, cryopreserved reproductive cells or tissues other than embryos that, at the time of donation, were exempt from the DE requirements, but were subsequently intended for a directed donation. Note that this is only for a directed donation and not for anonymous. And this exception may be used when additional donations are unavailable, such as due to infertility or the health condition of the donor, and appropriate measures are taken to screen and test the donor before transfer to the recipient. Now, the last exception here applies to embryos that were exempt from the donor eligibility requirements at the time of cryopreservation, i.e., they were originally intended for use in a sexually intimate partner, but are now subsequently intended for a directed or anonymous donation. So in this scenario, appropriate measures should be taken to screen and test the donor or donors before transfer to the recipient when possible. And for all of these exceptions, there are special labeling requirements that apply. Again, just like with ineligible donors, in some of these scenarios you might have known or unknown risk factors. And although FDA permits the use of these embryos under this exception, there is still a clinical decision that the establishment and treating physician may want to make as far as whether or not they actually want to implant these embryos into a recipient. So recently, an additional exception for embryos was added to the regulations. This new rule says that an embryo originally intended for reproductive use for a specific individual or couple that is subsequently intended for directed or anonymous donation for reproductive use is accepted from the prohibition on use under 1221.45C, even when the applicable donor eligibility requirements under subpart C of this part are not met. And I'll try to simplify in a moment what that regulatory lingo actually means. So however, the rule does point out that this does not create an exception for deficiencies that occurred in making the donor eligibility determination or in performing the donor screening or testing. Excuse me. And of course, if you use an embryo under this exception, then special labeling requirements must be applied. Okay, so what does this really mean? In general, this exception was created to better accommodate individuals or couples wanting access to embryos intended for reproductive use while continuing to emphasize the applicability of the donor screening and testing requirements for the individual gamete donors. So although the donor eligibility requirements still apply, this rule gives establishments the option to use embryos already formed even if a deficiency occurred when making the donor eligibility determination. So for example, if an establishment discovers that an error was made when screening an anonymous semen donor whose gametes were used to create embryos, for example, say the donor answered yes to a risk question, however, when making the donor eligibility determination, that answer was missed and the donor was inappropriately identified as being eligible when they should have been ineligible. So in this case, the establishment can still, and this is a scenario in which that error was not identified until after the embryos had been formed. So in this scenario, that establishment can still proceed with using the embryos under this exception. However, upon inspection by FDA, that establishment may still be held accountable for any deficiencies identified in their donor eligibility determination process, but the use of the embryo is permitted. So in other words, if FDA identifies that the mistake occurred because there was a problem in your quality program, then they may identify that as a problem during an inspection. However, just because they identify that, it doesn't mean you can't use the embryos. So that hopefully that explains a little bit what this rule actually means. But overall, it's just important to keep in mind that basically this rule is creating an exception so that embryos that have been formed can be used. There is a process in mind for you to be able to use pretty much any embryos that have been created. Now, as with all these past several slides that I have shown, which explain scenarios in which embryos may be used even when risks have been identified or risks are unknown, while FDA does not prohibit the use of these embryos, there may still be risk factors, and so an establishment or treating physician may want to discuss these risks with the intended recipient, and based on those risks may decide that they do not want to implant these embryos or make them available for subsequent donations. So even though the use is not prohibited by FDA, the establishment or individuals may choose not to use or make these embryos available for use in themselves or with other donations. Okay, so here, now I just wanted, we're about close to the end of this presentation, so I just wanted to provide some additional information about helpful resources, especially since the information that I've covered is really only an overview of some of FDA's policies. So here I provided a link to FDA's tissue homepage. This page will connect to multiple other pages related to tissues that contain helpful information, such as a page that lists all of the currently available tests that can be used for donor screening or for donor testing. I've also provided a link to the electronic version of 21 CFR Part 1271, so this is a very important resource to make sure that you have. And there are two different versions of the Electronic Code of Federal Regulations. This specific URL will take you to the most up-to-date version. I've also provided a link that provides additional information about tissue establishment registration, and a link to a page that lists all the HCTP-related guidance documents. Now, this next slide lists the specific URLs for the guidance documents that I discussed today, but I just want to remind you that all of these can also be accessed using the general guidance document link that I provided on the previous slide. So I also want to encourage you to sign up for automatic updates from FDA. Using the URL provided here, you can subscribe to the Biologics mailing list and receive notification about new guidance, new regulations, upcoming workshops and advisory committee meetings, and all kinds of other helpful information related to HCTPs. So even as an employee at FDA, I am subscribed to receive these updates, and I strongly encourage you to do the same. And lastly, I just want to emphasize that you should please feel free to contact FDA if you have any questions. Consumers can contact FDA at OCOD or OCOD at fda.hhs.gov. Manufacturers, which includes establishments handling reproductive HCTPs, can contact FDA at industry.biologics at fda.hhs.gov. So these emails go to our Office of Communication, Outreach, and Development, or OCOD. They are there to serve as a primary point of contact and to answer your questions as quickly as possible. If they are unable to answer your question, then they will forward your inquiry to the appropriate product office or division. Now, some of those, once inquiries get forwarded to those offices or divisions, a response might take longer. Therefore, it is best to go to OCOD first to see if it is something that they can answer right away. If not, they will forward your inquiry along to the appropriate personnel. So in addition, if you want to speak directly to a consumer safety officer or public affairs specialist, you may call 240-402-8010 or 1-800-835-4709. And again, these numbers go directly to our Office of Communication, Outreach, and Development. And I just want to thank you all for taking time out of your day to listen to this presentation, and I hope that you found this information helpful. Thank you.
Yeah, thank you, Michelle. That was wonderful. Just as a reminder for everybody who's still here, this webinar was recorded, and we will be sending out a link to the recording for any registrants along with a copy of the slides. So all of those helpful resources and links that she provided you will have access to. And if you have any further questions, you will also have that contact information so you can reach out for whatever that might be. So thank you so much for everybody that attended. We really appreciate